So this one, unfortunately, is not one we can rush through. It's a big chapter. It's a huge chapter. It's an important one on ACS and antiplatelet agents. And there's a lot of sub-issues in here, some of which we can hurry through and some of which we can't. So let's just start out. What are the great new breakthrough drugs for cardiac disease? Well, there aren't any. Okay, the great new breakthrough drug is aspirin. Okay, aspirin is, if you actually go look at, you run the numbers, aspirin has more effect on cardiac outcomes, long-term and short-term, than any other drug, by a factor of many. And so that's it's pretty sort of fascinating. It's also makes it easy for us. The famous aspirin reference is number 2, which is the ISIS-2 study. And the ISIS-2 study is only one little aspect of it. This is the aspect of aspirin when you've got a STEMI and you're giving and you're considering an intervention. And this study was 17,000 patients, published in '88, I think, in BMJ or Lancet or something like that, Lancet. And they took all these patients and they randomized them into 4 groups with a STEMI. You got aspirin, you got streptokinase, you got both, or you got neither. And compared to neither, aspirin produced a relative 23% or 21% decrease in mortality. Pretty good. Okay? Relative is not absolute. So relative means you went from 10% to 8%. So only 2 out of 100 actually benefited, but the relative benefit was 1/5 or 20%, just over 1/5. This was only for STEMIs, okay? If you got streptokinase versus nothing, you got a 23% relative benefit. So 2.1% absolute benefit. And the difference, of course, is trivial and not statistically significant, chance alone. So both of them worked. Both were important. Both are not earth-shaking, but they were important. And if you gave the 2 together, you got a 41%. The numbers, you'll look at the numbers, it may be 43. I can't remember, but it was very close to the numbers I'm telling you. So that they actually worked together. It was better to give both than just one. So that was aspirin. And this is only for STEMIs. Now, we do know that streptokinase, so let's just go talk about which is better. I just said aspirin's better than streptokinase. Streptokinase was marginally better than aspirin. So why did I say aspirin was better? Well, because first of all, you can give aspirin to non-STEMIs. And you can't give streptokinase or TPA, they're the same, to non-STEMIs. Thrombolytics are only good for ST elevation MI. And in fact, there's good evidence that even if you have an MI, but you don't have ST elevation, giving a thrombolytic is harmful. It's not only not beneficial, it's harmful. Whereas giving aspirin is beneficial. Oh, and by the way, aspirin's also beneficial for ACS without an MI. Whereas, of course, thrombolytics are not. So for all those reasons, aspirin is much more valuable. And there's another reason, which is that the vast majority of MIs can't get a lytic, whereas they certainly can get aspirin. So aspirin's really, really important. Many, many studies in many different venues have shown this, but this is the most famous one, and this is just for STEMI. The next 2 articles are about what's the optimal dose, and they all say the optimal dose is little, but not so little. So they all talk about giving an aspirin. And there are all these people who say, well, you don't want to give 60 milligrams, and you don't want to give, you don't need to give more. But the truth is that that's all made up. There is no evidence that I can tell that says the dose really matters. So 1 aspirin is fine, but if you gave a baby aspirin, it would probably be fine too. The cardiologists say, no, not a baby aspirin, a whole full aspirin. And what about if you're not sure if they took an aspirin already today, and you ask them and they say, I don't remember if I took an aspirin today? Give them an overdose. Give them the second one, that even if they took it, it's not a big deal. Aspirins are pretty much a no-brainer. The next thing is heparin, and it's sort of fascinating that this chapter is really weird, because the chapter is written by Mel Herbert, who's really smart and knows a lot about this, and I think comes to all the right conclusions if you read his in between the abstracts, but for some weird reason he included the wrong abstracts and excluded the important abstracts. And the reason it's so weird is because Mel knows better, and because the first article in here on the section about heparin, number 5, is about the myth that heparin is useful. And the author is Scott Brewster, who used to be my resident, and Mel Herbert, who also used to be my resident, who wrote this chapter. Mel was the second author of this. And the myth is heparin is useful. And the article points out that heparin is not useful, and it cites all the important evidence. So with all that, in fact, you would think that in the chapter he would have cited the important evidence besides his own article. And unfortunately, he leaves out the most important one. And so if you were to go abstract by abstract through this section, you would say, that's not a myth. It looks like heparin is useful. But in fact, heparin isn't. He's right. He just forgot to cite the important articles. So what does he cite here? He cites a few little studies where somebody gave heparin versus not, and heparin worked. So why is it a myth? Well, because the issue isn't whether or not heparin is better than nothing. The issue is whether heparin and aspirin is better than nothing and aspirin. And the studies that he cites here are almost all nothing versus heparin. So what's the critical article? The critical article is by Collins in the BMJ in September of 1996. If you want to look it up, you can look it up. Why is it critical? Because it's a meta-analysis of all the big studies of this. And it says, if you look at heparin versus nothing, heparin works. But if you look at the 5 megatrials with 68,000 patients comparing heparin and aspirin versus nothing and aspirin, there's no difference. Well, I actually lied. The difference is 1 in 1,000 patients benefits. And then, if you sub-analyze it into who is the patient who benefits, it's the sickest patients. So if you look at low-risk patients, they don't benefit. If you look at moderate-risk patients, they don't benefit. If you look at high-risk ACS or MI, there is a 1 in 1,000 benefit, which, by the way, comes at a cost of more than that amount of increase in major bleeding. So, ultimately, the appropriate thing to say is, rule out, they shouldn't get heparin. They should get aspirin. Moderate risk, you can do whatever you want. High risk, they have ST elevation, they have a troponin leak, do whatever you want. MI, they're having a STEMI, whichever you want. I personally, having looked at this literature in great detail, don't use heparin. And I don't think it's additional to things that we do for even STEMIs. In here, he also cites the HEART study, which was the study about adding heparin to TPA. And nowadays, how many of you still use TPA? I don't know if we should even talk about this. TPA for MI. So I shouldn't be saying TPA, I should say lytics, but in the United States, that means TPA. Despite the fact that there's a lot, we don't have time to go over the whole story, but I'm pretty certain that streptokinase is exactly as good as TPA. And that there's the attempts to make it that TPA is better are silly. And one of the ways in which they did that was they cited this HEART study. So I'll just tell you the really quick and dirty, because it's a great story, but we have to rush through it. When they were fighting about TPA versus strepto, TPA in the United States was winning the battle. Everybody was using TPA, even though there was no evidence it was better. And then along came the Europeans, and they did this terrible thing. They actually compared the two. They did 2 major mega trials where they compared TPA versus strepto. And what did they find? They were exactly identical. The only difference was TPA cost a lot more and caused more brain bleeds. That was the only differences they could find. Oh, yes, there is 1 out of every 10,000 patients who's allergic to strepto. But overall, strepto was just as good and caused less bleeding in the brain. Every other outcome was the same. So that was really bad for the makers of TPA, because even though it was only Europeans, so they don't really count, it finally started to get across the Atlantic, and people were saying, well, why are we using this drug that's 10 times more expensive and causes more bleeding and doesn't have any benefit? So it was at that point that the makers of TPA decided to do the Gusto trial, or as some people call it, the Disgusto trial. And they sponsored this trial, and they compared TPA versus strepto. Now, there were 70,000 patients or 60,000 patients studied in Europe, showed no difference. So how could you justify ethically doing a new trial? You can't. But they did it based on this thing called the HEART study, which is in here. I'll tell you, it's number 10. And the HEART study said that if you give TPA, you have to also give heparin. Now, some of you remember way back when this was being discussed, when they first came out with TPA, they said it's worth 10 times more than strepto because it doesn't cause a systemic lytic state. Strepto causes systemic lysis, whereas TPA was only clot-specific and wasn't that great, and it was going to lead to less bleeding. That's what they said. That's why we should spend all the money. It would be safer because you had this drug that didn't cause systemic lysis. And so it turned out that wasn't true. It caused more bleeding. It didn't cause less bleeding. But that was no problem. But along came these European studies where they didn't give heparin with it, and they found no difference. And all of a sudden, the makers of TPA found an excuse to say the European studies didn't count. And they said the European studies don't count because they didn't use heparin. And TPA needs heparin because we don't do a good enough job of causing systemic lysis. It's sort of ironic because at first that was the benefit of it. And now when it turned out it didn't work, they said, no, we're unfairly penalized because the other guy gets to cause systemic lysis and we don't. And we need it. And we know that heparin is really good for TPA based on the HEART study, which you have here. And the HEART study, you can look at it, was all of 200 patients. And what they found was they randomized them, they all got TPA, and they randomized them to yes or no heparin. And they found that the heparin group did better, just like TPA claims, right? And how do we know they did better? 80% had an open vessel versus 50%. Now, the numbers are so small that that's, who knows whether that's a real difference. But 80% had an open vessel versus 50% had an open vessel. So they said, see, TPA needs heparin. And therefore, the European studies which didn't all use heparin, they don't count. So therefore, we're going to redo this study with heparin for TPA. What they forgot to mention about the HEART study, besides the fact that it's tiny, was that the outcome they measured is not a real outcome, is it? That's not, they had less death, they had less bleeding, they had less heart attacks, they had less congestive failure. It's what happened on the angiogram. And it was one of the old myths, one of the longest myths of the TPA thing was the open vessel hypothesis, that the more open vessel you had, the better it was. But in fact, there was lots of evidence before the HEART study that it didn't matter how many vessels you opened, because in fact, that was the only advantage of TPA compared to streptos. You open more vessels, but it didn't translate into patients do better. So actually, the dirty little secret in the HEART study is that there was no advantage in any of the patient-oriented outcomes. There was no less failure, there was no less arrhythmias, there was no less death, there was no less nothing in the patients who got heparin. They were just better vessels on angiogram. And in fact, there were 4 times as many bad outcomes in the heparin group. So the whole basis for this is a myth. This is cited as you need to give heparin with TPA. In fact, there's no evidence of any benefit to patients. Now, I said 4 times as many bad outcomes, it was just MIs. So there was one outcome that was worse with TPA, with heparin. All the others were the same. But it's certainly not evidence that you really need to use heparin. But nowadays, everybody who gives TPA gives heparin. Oh, by the way, it's been studied explicitly for strepto. There's no advantage to heparin. And by the way, when the heart-treating study came out, and when they used it as an excuse to do gusto, there were 3 other studies which also did heparin versus non-heparin when you use TPA, and none of them showed any measurable advantage of using heparin. None. And one of the interesting, my favorite part of this whole story, this was the whole basis for rejecting the obvious conclusion from the European studies that there's no difference between TPA and strepto. None. They rejected it based on this study. And so they did this new study called the Gusto study. I'm not going to tell you all about it, but the first author of the Gusto study was a guy named Eric Topol, whom some of you have heard of. He's a famous cardiology researcher. And he did this work for the company that makes TPA, and was the first author of the Gusto trial, which showed how important this stuff is. And when they justified doing the Gusto trial, they based it on this study, that you must use heparin if you use TPA. It was the only study they cited, even though there were 4 studies at that time, the other 3 of which were completely negative. But what was really interesting about it was that the largest of the 4 studies that were available when they justified Gusto trial was done by some guy named Eric Topol. He was the first author on the largest study which showed it was useless. And he never mentioned that when they did the Gusto trial. He forgot that he had done the study. I mean, this is stuff you can't make up. It's really bizarre. Anyway, so nowadays people say, well, you should do it if you're going to give TPA. But as far as I'm concerned, is no evidence of utility in that circumstance. And there's no evidence of utility in any of these other circumstances either. So heparin, you can use it in the high-risk patients. Please do not use it in the low-risk patients. And I don't use it in anybody for ACS. Okay, but heparin at least is not that dangerous. It's a little dangerous. And it doesn't cost anything, except for nursing time and stuff like that. The next little stuff is, what about special heparins? So the disadvantage of heparin is it doesn't cost anything. So we have low molecular weight heparins. Even they are falling out of favor now because they're going off patent, which is the best reason for a drug to lose its potency. But so the next few articles here are about low molecular weight heparin, and they basically show when they first came out, when the first few articles on this were published, I thought, this is great stuff. Look at this. It must be not really heparin. It's something special. And because the first few articles said it's much more effective and much safer. And then a few years later, there were a whole bunch of other articles, and they showed that it wasn't more effective, but it was safer. And then the next series of articles showed that it wasn't more effective, and it wasn't safer, but it wasn't worse. It was non-inferior. So all the current studies show that they're all non-inferiority studies, which show it's not worse than regular heparin. But it is heparin. It's just a different version. And in fact, the one real advantage of low molecular weight heparin is you don't have to measure anything, and you give it sub-Q, you don't have to put it in an IV, you don't have to keep the patient in the hospital if there's something they could go home. That's the one real advantage of low molecular weight heparin. It's not a different drug, it's not better, it's just the same drug, you don't have to measure it. Oh, by the way, you could do the same thing with standard heparin. Sub-Q standard heparin, you don't have to measure anything. And the 2 studies in DVT, VTE, where they've actually looked, could you send the patient home on sub-Q low molecular, standard heparin, had exactly the same results as when you do low molecular weight heparin. Now, none of you are going to do that because it's too cheap, and therefore nobody's making any protocols to do it. But in fact, it is no different than low molecular weight heparin. So it's not an advance, it's just a different form of the drug. But this will be moot any day now because more and more of them are going off patent, so we have only the new guys now. Nobody's terribly interested in low molecular weight heparin anymore. So the next series of articles on here are about, and you can follow it in here, there's a couple articles on fondoparin. I'm going to skip that because I just don't think it's important enough, and you're probably not getting bombarded with this stuff anyway, right? Nobody's pushing this right now. It's not going to go very far. So the next one is Clopidogrel. I got to spend a minute on Clopidogrel, and then I'll stop. No, I want to say something about glycoprotein inhibitors as well. Those are 2 important topics. GPIs are not in here, but I want to mention it. Clopidogrel, the most important study is number 26, is the CURE study. It was a manufacturer-sponsored study, and it was the one which put Clopidogrel or Plavix on the map. At UCLA, they don't call it Plavix, they call it Bleedix. That's what the internal medicine residents call Plavix. They call it Bleedix. I didn't make this up. I heard this. I thought, what's that? And anyway, so, but the literature says it doesn't cause a lot of bleeding. And in fact, it's sort of strange because my experience is a lot of bleeding, and that's apparently a lot of people's experience, and yet the literature says it's pretty safe. It doesn't cause a lot of extra bleeding when you add it to aspirin. Well, it causes some, but not that much. So what is the CURE study? It's 12,000 patients, very high acuity ACS patients. no ST elevation. They got aspirin plus clopidogrel or not clopidogrel, and they found that the clopidogrel group was better. The number needed to treat was 50. That means for every 100 patients you gave it, 2 people did better. And what did they do better with? They did better on a combined outcome of cardiovascular death, that's an important outcome, stroke, important outcome, or recurrent ischemia. Well, that could be an important outcome. You're having a re-MI. That could be important, but maybe it isn't always important. So what was it really? So when you actually looked at the 100, when you actually looked at the every 100 patients, 2 did better, there actually was no difference in death, and there was no difference in stroke. There was only difference in recurrent ischemia. And what did you have to be recurrent ischemia to get classified? No, you didn't have to have chest pain. You had to have a troponin leak. They serially measured your troponins, and the clopidogrel group had more episodes where there was a troponin leak. They don't tell us whether a single patient more complained, or had trouble breathing, or had an arrhythmia, or
the non-clopidogrel group had more troponin, right?
Non-clopidogrel group had more troponin leak. That was the difference. Now, they might have had more chest pain, I don't know, but you didn't have to have chest pain to have it, and they don't break it down like that. They don't tell us, was there anybody who was affected? Was there a human being who had a worse outcome? We don't know that. What we know is that they had more recurrent ischemia by this definition, which included if you had a little troponin leak and you didn't have one single symptom. So that's one of the interesting things about this. That's the basis for saying clopidogrel is important. That is it. Oh, by the way, there's more to the story about this. So number 27 is more drug company stuff on this, but number 28 is a really wonderful article called Is Cure a Cure for ACS? And it's a critique of the Cure trial. And it said, it doesn't talk about all the things I'm going to tell you about, but it points out that there are a couple of things that are really interesting about Cure. One is that there was very little bleeding in the Cure trial. The clopidogrel group had very little increased bleeding. It was pretty safe. But you know, the guy said, you know, I was at the meeting at the European College of Cardiology where they reported it, and at that meeting there was a lot of extra bleeding. What happened? So did they just add more patients, and after a while it turned out there was no, it wasn't that they added more patients. They reported all the patients. Between the time they reported at the European meetings and the time they published it in the New England Journal, they changed the definition of bleeding. Major bleeding changed, and now it wasn't so bad anymore. So when they first reported, lots of extra major bleeding, and now they said, no, that wasn't really major, we're not counting it. That's sort of interesting. A second thing that they did that this guy talks about is this was all people who went to PCI. But in Europe, where the study was done, they don't do PCI right away. They do it 3, 4, 5 days later. And he said, you know, if there was extra major bleeding, even a little, it's probably going to be much worse if you go do a procedure on them right away than if you wait 4 or 5 days. So maybe that's a difference. He also pointed out something particularly interesting, which is that, so let me back up for a second. We talked about this the other day. If I have a drug for any condition, it always will cause some harm. All drugs have side effects, and it might have benefit in the condition I'm looking for. If that's true, we always want to balance harm and benefit, right? The more patients I give it to who stand to benefit because they really have the disease or because they're really at risk, the better the benefit, and that might outweigh the harm. The lower the risk patient, the less benefit I'm going to have, right? Because they're not going to get sick anyway. And if there is some harm, the harm might outweigh the benefit. So all studies, you can look through anywhere in the cardiac literature, you'll see this thing called high acuity bias. That means they like to only have high-risk patients, not moderate risk and low-risk patients. Because a low-risk patient can't benefit, but they could still get harm. You throw in enough of them, and overall it's going to look like more harm than benefit. So you want to have the ideal group, which is a high-risk patient, right? Makes sense, right? You also, by the way, don't want to have, you have a different type of bias for chronic disease. You don't want the patient who's really, really sick who's going to die anyway. So you want to have somebody who has no chronic disease. You always exclude them. You exclude the elderly. And you exclude the moderate and low-risk patients. You cherry-pick the ones you want to have. When you report it, the drug rep doesn't say, oh, by the way, don't use this in all your soft rule-outs. They only say, oh, it's great for rule-out, right? But they don't want to tell you that maybe it's not so good for the low risk. You only want to use it for the high risk. Well, the CURE trial, turns out, proved what I just told you. Because it's a 12,000 patient study, but the first 5,000 patients, they included moderate and high-risk patients. No low risk, moderate and high-risk patients. And they peaked at the end of 5,000 patients, and guess what they found? Increased bleeding, no benefit. So they changed the rules in the middle of the study. And they excluded all the moderate and risk patients. So the next 7,000 patients only included people who had either a troponin leak at the start or ST depression or flip Ts. So they were the really high-risk patients. And it was in that group where there was a 2 out of 100 benefit. So this study actually proved something that I've been saying for years, which is don't extrapolate from studies to low-risk patients. Don't extrapolate from high acuity bias studies to moderate acuity. This study actually proved it. They said you should not use this in moderate risk patients. They proved that. How many of you have heard that from the drug rep? Do not use this in anybody who doesn't have a troponin leak. Of course not. But this study actually proved it. So I personally think, and then there's other problems with Clopidogrel, which number 29 mentions. 29 says, what if they need to go get cabbage? Well, no cardiac surgeon will do it. It's really a problem. What if they fail the stent? Because no cardiac surgeon is going to do it. Too much bleeding, even though Clopidogrel didn't have much bleeding. By the way, how many of you know an orthopedist who won't do a procedure on a patient who's on Clopidogrel? Or an ENT, surgeons hate this stuff. They hate it. So, and that's another problem, because once you start them on Clopidogrel, you can't take them off of it, because there's this tremendous phenomenon of reocclusion of the graft or whatever it is. We're getting strokes or clots when people are stopped from Clopidogrel. So once you start it, when they're on it, there's high risk of bleeding. If they need a procedure, you can't do it. But you can't, it's really problematic to stop it, because now they're going to reclot. Nevertheless, Clopidogrel is $1 billion a year drug. Pretty remarkable. So that's Clopidogrel. I personally, I don't lie down on the tracks when the cardiologist wants to do it, but I don't start it. So the cardiologist wants to take the patient to the cath lab and they want them on Clopidogrel, their funeral. But it's not, or the patient's, but I don't do it. But I certainly, I won't start this on my patients. I also talk to patients about it, which is a novel concept. Now, I'm just going to spend one more last minute, which is on glycoprotein inhibitors. Oh, 2 last minutes. One is on glycoprotein inhibitors. It's a bonus for this chapter because it's not in there, but it's really important. And the other is facilitated PCI. There is one study in here, the ASCENT trial, which mentions it, so I guess I ought to mention it. It's important to mention. How many of you work in a place where you do PCI? How many work in a place where you don't do PCI, but you transfer them somewhere where they get PCI? And how many work where you give them lytic? So we have a little of each of these. Okay. So there's pretty good evidence that it's better to do PCI than a lytic. And even if there's a delay, and we don't know exactly how long, but at least 2 hours we know it's better to actually transfer them and do the PCI. Now, I mentioned the other day that it's probably not a one-size-fits-all, and probably if you're hyperacute, delays are bad. So that if I were having an MI, just had chest pain, I had ST elevation, and it was an hour delay to get to PCI, I'd want the lytic, even though I can't prove that to you. Nobody has studied that, nobody can. But we do know that delays early on are really, really important. So that if you get your lytic in the first hour, it's it's much better than I told you. It's not 2%, it's much, much better than that. Whereas if you get it at 3 hours versus 5 hours, there's no difference. So delay, once you're past the hyperacute stage, doesn't matter. And their PCI is better. So once you pass the hyperacute stage, they should be transferred, if you can do it. But in the hyperacute stage, I suspect that it would be better to do whatever you can do quickly. In any case, along came this notion of, I work in a place where I got to transfer them, there's going to be a delay, maybe I should give them a little lytic now, and then send them over there and get the stuff. We do know from other studies, from long, long history, that you shouldn't routinely do both. You should do one or the other. And if you do a lytic, you shouldn't follow it up with PCI, not routinely. Rescue, that's one thing. The patient failed, then you should, but not routinely. But here's a different question. What if it's going to be a delay to PCI? Maybe I'll give them a half dose. So there are now about 8 studies of this. Concept is called facilitated PCI, and every single one of them shows that it's not beneficial, but it is harmful. Causes more bleeding, no benefit, and sometimes fatal bleeding. So we shouldn't do it, okay? They're continuing to study it. There are more studies in the line because one time it won't look so bad, and then they'll be able to recommend it. PCI is really, and that's true, that's what they do all the time. Because, there's a bell-shaped curve in studies too, and some studies show it's really terrible and some show it's moderately terrible. There'll be one that shows it's sort of neutral, and if you look on Tuesdays in people who have a last name that starts with the letter M, it's better. And then you'll be able to extrapolate, well, maybe Tuesdays and Wednesdays are sort of similar, so maybe we should do it in everybody. That's how these studies are often done. You've all seen studies just like that. And to me, it's extraordinarily unethical that they continue to study this after every study has shown it causes harm. But there are big studies out there right now on this. Anyway, but we shouldn't do it. And the last thing I'll just mention is glycoprotein inhibitors. This is apixaban, which is RioPro, right? And in the same way, one might ask, is it useful in people who are going to the cath lab? Is it useful in people who are high risk, not going to the cath lab, low risk, medium risk, et cetera? Those are better questions than should I give it to everybody? What do we know? There seems to be evidence, I think everyone sort of agrees, that these drugs are useful in people who are going to the cath lab. Now, there are some people who know more about it than I do who say, not so fast, but I'm willing to agree that it's useful if you're going to the cath lab. Amongst those patients, there's good evidence that apixaban, which is much longer acting than the others, is better than all the others. So RioPro is better if you're going to the cath lab. And it seems to be better in every way you can measure, okay? Then the question becomes, what about the patients who are not going to the cath lab? That's the vast majority. I want to sell this drug. I don't want to sell it to people who are going to the cath lab. I want to sell it to rule out MI. Right? Most of those people don't go to the cath lab. So there are now multiple meta-analyses and systematic reviews and guidelines, all of which say you should give it to rule out MIs. Some say high risk, some say medium risk, whatever. It doesn't matter if they're going to the cath lab or not. There's only one study which actually addressed that. That was called Gusto-4, 7,800 patients. It was an apixaban study. They looked at, is it better if you're not going to the cath lab to get apixaban versus get all the other things you get? And what did they find? It was worse. It was worse. So there's one study, big study, 7,800 patients with the best of them. Apixaban says if you're not going to the cath lab, do not use this. How many of the guidelines changed? Said don't use it. None. What do the guidelines now say? Don't use apixaban. Obviously, apixaban, it's got its own problem. We don't know what it is. Use the other guys. They're worse in every way we could measure, but fortunately, we don't have any study proving that they're bad, so we can continue to claim that they're good. But I think that's tragic. I think it's just the more of the same and really bad. And so, personally, I think my own belief is that we should not be using these drugs, the glycoprotein inhibitors, unless the person is going to the cath lab. And once again, the cardiologist who's going to the cath lab can make that decision. But I don't, just completely ignored. Anyway, that's it for this. Any comments, questions, thoughts?